Good morning, everyone. We are really excited today to have Dr. Eric Weinhandl present to us about the epidemiology of end-stage kidney disease, not renal disease, in the United States. Dr. Weinhandl is a PhD epidemiologist. He's been actually, interestingly enough, he's been in nephrology since he was an undergrad. When he was introduced to the field of nephrology, and has been doing epidemiology work in nephrology ever since. He's worn many different hats, but I think almost throughout his career, he's been a co-investigator in the USRDS at the Chronic Diseases Research Group in Minneapolis, though I think the USRDS has shifted on and off, but it's been mostly been in Minneapolis. He's also worn other hats in industry that I'm sure he'll talk about, mostly because he's a home hemodialysis champion. But today he's going to mostly talk about epidemiology of end-stage renal disease. Welcome, Eric.
Well, thank you, and thanks for having me, everyone. It's nice to be here this morning. I have a little bit of a connection to Canada, aside from my geographical proximity of living to Minnesota. My grandparents left Austria after World War II and actually settled in Winnipeg. And so I have a lot of relatives in Winnipeg. My grandparents lived there for about 10 years before moving to Minnesota in close to 1960 or so. So that's my natural connection. All right, well, I will get started here. I have a lot of content to get through, and I definitely want to leave plenty of time for your questions and for conversation. As far as disclosures go, I tend to have a pretty simple profile of conflicts of interest. I'm here today as a representative of the USRDS on the work that's done there. I do want to disclose that my full-time employment, by which I gain my living, is with DaVita Clinical Research at present. I spend most of my time on home dialysis there. Both HHD and PD. I have no other conflicts of interest, no other entanglements or receipt of money from industry sources. All right, so what is the USRDS? It is a registry. It's clearly a registry of end-stage kidney disease, as it's well known across the world, but it is in some respects very different than many other registries around the world, particularly in the Western Hemisphere. And that is because it is fundamentally passive. The USRDS doesn't create tools of its own for collecting data. It doesn't have the power to collect data that it doesn't otherwise have. All it can do is analyze data that exists in secondary sources. Now, there are some historical exceptions. Back in the 1990s and early 2000s, the NIH issued separate contracts from the USRDS Coordinating Center that were known as special study centers. And those special study centers did have the opportunity to design their own prospective data collection studies, but those contract vehicles don't exist anymore. So the USRDS really is a fundamentally passive registry that is simply here as a clearinghouse and organizer of data. The website can be accessed still to this day at usrds.org. The government has converted most web addresses to NIH addresses that have a much longer URL, but thankfully that one still redirects because it's a very simple address to type into your browser. The USRDS website has been in its current form since about 2020 or so, when it decided to move to the format of live graphics that one could interact with, as opposed to PDFs that were static. No longer is a paper copy of the annual data report created. I was around back in the very early 2000s when Alan Collins was the director, and we would go to a printing house in Minneapolis, and he would insist on having the annual data report printed at a book about this thick. It was about 1.5 inches thick, printed on the highest premium glossy paper. It was an entire production. That system is long gone, and now we live entirely in electrons. So the federal landscape is interesting, and I wanted to spend a little bit of time this morning describing how the USRDS comes to be in the United States, because I want to take this opportunity to provide you with a little bit of context as you're interpreting data, not necessarily just the data that you encounter in the annual data report, but more importantly, there are so many original investigations that end up published in JASN and CJASN and in other high-profile journals that use USRDS data, and those do end up driving conversations, potentially treatment decisions. And it's important to always understand where these data come from and the limitations around their interpretation. As far as the federal landscape goes, within the Department of Health and Human Services at the federal level, we of course have the NIH, and then within the NIH is the National Institutes of Diabetes and Digestive and Kidney Diseases, or the NIDDK. And then within the NIDDK are multiple divisions, including kidney, urology, and hematology, or KUH. And KUH has the opportunity, of course, like any other NIH division, to issue R01 grants, R03 grants, investigator-driven studies. The USRDS is not a grant. It is actually a contract. And as such, it goes through a rebid cycle every 5 years. Now, there can be extensions, but the ordinary cadence is every 5 years. An RFI will be issued to the entire country. Anyone is invited to submit an application to become the next USRDS contractor. And that proposal for the contract involves both a technical application and a business application. And so the technical application involves all the science, how you handle the data, what are your ideas for scientific investigations, how you innovate the annual data report. The business application involves business, including an actual amount that one bids. And that bidding amount certainly can be the driving factor. Back in 2014-15, when the contractor moved from Minneapolis to Michigan for a period of 5 years, the dollar amount actually became a very important issue in terms of the decisions that the NIH made about who to make the USRDS contractor. So it's not entirely about science here, unlike grant applications that might go through a scoring system and then, above a certain percentile, the grant is funded. Currently, the contractor of the USRDS is the Chronic Disease Research Group, which employed me for many, many years, and I have still many deep relationships and work with them. I just don't receive any money anymore. It's a division of Hennepin Healthcare Research Institute based in Minneapolis, Minnesota. Hennepin is a safety net hospital in downtown Minneapolis, longstanding research arm as part of it. It is not a glitzy looking hospital by any stretch, but it is a fantastic place to receive healthcare, I will say. I put one other circle or oval to the upper right, and that is that there is CMS lurking about all of this. I made the point very early on that this is a fundamentally passive registry. That landscape from NIH down to USRDS is not collecting data about end-stage kidney disease that ends up in the USRDS. All of the data that powers the entire USRDS comes from the Centers for Medicare and Medicaid Services. All of the data that they collect about the incidence of ESKD and deaths and claims data, it's all coming from them. And so, although there is this entire cadence of decision-making about what the content of the USRDS will be, there is still a dependency between federal agencies whereby CMS must provide the data to the USRDS, and that lives on its own schedule. And so if you open up the USRDS website today and say, why is there only a few chapters posted? The answer is because this year, CMS was not able to deliver Medicare claims data to the USRDS contractor until the very beginning of June. Some years that's as early as February and March. And so this dependency, which is very much outside the contract, looms over everything that the USRDS does. CMS really does provide the fuel for USRDS. So when we talk about counting people with end-stage kidney disease, in fact, there is a form. This form still goes by the moniker of end-stage renal disease medical evidence report, but this form is sometimes known as 2728 for its federal number. This form is submitted every time a patient either receives a kidney transplant or initiates dialysis in an outpatient setting. And so it's important to remember there, some loaded language, that the USRDS is counting patients with kidney failure that results in kidney replacement therapy, and specifically kidney replacement therapy in the outpatient setting. It is not the same as estimating the incidence of kidney failure on the basis of a GFR under 15 for a persistent period, or the receipt of any dialysis, including chronic dialysis, exclusively in an inpatient setting that never progresses to an outpatient dialysis facility. That's a bigger incidence pool. This is a more tightly confined one that involves treated ESKD in a dialysis center or receipt of a kidney transplant. This form is submitted virtually by everyone. Yes, there are undocumented immigrants in certain parts of the country that seem to escape through the system. A 2728 form, this form is never submitted, and the USRDS has some capability for identifying those patients with varying degrees of success. But this really powers the count of who has ESKD in the US. Similarly, when it comes to cause of death data, in the mortality chapter of the USRDS ADR, there is a pie chart that has existed for a very long time having to do with cause of death. That information exclusively arises from this form, and this form is mandated to be submitted every time a patient on dialysis or even a patient with a functioning graft expires. Now, is it always submitted? No, the success rate is approximately 80% in the dialysis population and actually a fair bit lower in the transplant population. So when you're interpreting the cause of death fields in the USRDS annual data report, just keep in mind it's not capturing everyone, it's just capturing the majority, particularly particularly in the dialysis population. But again, this cause of death information exclusively comes from here. You can see the field at the very bottom where you can enter the primary cause of death, along with a variety of entries about secondary cause of death. The USRDS is not pinging the National Death Index, which is the death certifications or death reports, certificates that are ordinarily completed by a coroner. There's no clear pathway whereby that data flows from state to federal government back to the USRDS. So this has to be the tool that allows us to assess cause of death. All right, the US is obviously a multi-payer environment. I'm sure you all know that and probably are pretty happy about that, that you're not in this environment. But the USRDS annual data report is the same way. It is a multi-payer environment. And I think that this is actually one of the things that if there's no wonky detail that you remember today, I hope you remember this one, because it changes the interpretation of every figure that you look at. You're not always looking at the entire population of patients on dialysis. I've listed the chapters in the ESKD volume from 1 to 10 with the exclusion of some chapters that change from year to year. And I've included information about the payer that's covered or the payer frame that's covered in the far right column. You can see that we have certain chapters that are in fact payer agnostic or all payer. We know incidence and prevalence for everyone who's on dialysis and has a transplant. For home dialysis in general, when it comes to modality mix, we know about everyone. Varying degrees of success when it comes to understanding the fine details of the prescription, particularly when it comes to home therapies, but we do know what modality people are using. I'll get into clinical indicators a little bit, but after that, things really change and they become very heterogeneous. Vascular access is a mix. It's a chapter that includes information about what type of access a patient is using for all payers, but there are figures in that chapter about patency of the fistula, and those figures are exclusively in Medicare fee-for-service. Hospitalization is a big flashpoint. For hospitalization, historically, it's been entirely driven by Medicare fee-for-service. Which once upon a time was a large swath of the dialysis population, and today is this progressively shrinking one. I'll show you a figure in a moment. There's some expansion into Medicare Advantage, but that's a real hornet's nest of data. And then you can see the situation changes thereafter. Importantly, as far as the final row is concerned, prescription drug coverage, which is well characterized by the USRDS with a lot of figures, both in chapters devoted to oral drugs, as well as individual figures sprinkled into other chapters. Is being driven by Medicare Part D data. Now, Part D data, technically speaking, is collected by anyone who is enrolled in a prescription drug plan, whether that's through traditional Medicare or Medicare Advantage. But it is important to remember that for those who are in traditional Medicare, purchasing prescription drug coverage is potentially a choice you have to make that involves spending some money on a monthly premium. And so it isn't like everyone has prescription drug coverage just because they're already enrolled in Medicare. To unpack this a little bit, I wanted to make a mention of the clinical indicators chapter because there's a rich amount of data in there about the fine details of the biochemical status of a dialysis patient, if nothing else. CMS actually does collect data from all Medicare certified dialysis facilities through a system called the NxStage Renal Disease Quality Reporting System, or EQRS. And this actually is an important backbone of the entire registry. You don't really see a lot of references to EQRS throughout the USRDS ADR footnotes and such, but it is lurking behind all of this because this really is the tool. This is what CMS would call its registry of patients. Now, I made mention of Medicare certified dialysis facilities. Almost all facilities in this country that are freestanding dialysis units are certified by Medicare to provide coverage to beneficiaries of Medicare. There are a few exceptions. The Veterans Administration, which operates this relatively small network of dialysis centers across the country and cares for, we'll call it, close to 1,000 patients on chronic dialysis. Their facilities are not Medicare certified. So there are a few leaks throughout the system. A brand new facility that is potentially just been opened, it may not yet be Medicare certified, but may be already rendering dialysis to patients with private insurance. So there are these exceptions around the margins, but generally speaking, this is actually everyone for the most part. There are important details included in here, but I want to highlight about the data types, the biochemistry. Medicare does collect a variety of biochemical quantities related to clearance, anemia, iron parameters, mineral bone disease, and albumin. This data is reported monthly or quarterly, and I specifically want to mention the UFR because there have been a number of studies over the years that have attempted to estimate associations of ultrafiltration rate, particularly in in-center hemodialysis with clinical outcomes. UFR data is collected by way of the KT over V data that's collected. So the government requires that a dialysis provider report pre-dialysis BUN, post-dialysis BUN, the length of a treatment, and obviously the fluid parameters necessary to calculate the UFR. That data is collected once per month, one session, and it's typically by regulation the last hemo session of the month. So anytime you're looking at UFR data that's been, say, gleaned out of the USRDS standard analysis files and put into original investigation, just keep in mind that this is not UFR from every session. It can't be like you would get from a dialysis provider data set. It is just once a month UFR. And it's from a session where it was anticipated that the patient was likely to have adequate clearance, a single pool KT over V above 1.2, given the nature of reporting and the incentives involved. So there's always caveats lurking behind these things. Now, I've made mention of Medicare claims, and Medicare claims are very important. USRDS research relies on Medicare claims data, and these claims can arise from facilities or physicians. Facilities include hospitals, dialysis centers, ambulatory surgical centers, any sort of building can submit a claim. And then physicians individually submit claims, whether those are nephrologists or cardiologists or whomever. For many years, fee-for-service Medicare ruled in this country. And fee-for-service Medicare is sort of a catch-all for this two types of insurance called Medicare Part A and Part B. Part A is hospital insurance that covers receiving care in a hospital as well as receiving care in a nursing facility after being discharged from the hospital. Medical insurance covers your clinic visits, essentially. The former is an entitlement. The latter actually carries a monthly premium. And so people do have you'll see this occasionally in this country. People have Part A insurance, but not have Part B insurance, which is a strange situation, but it often happens because somebody is coordinating Medicare with a different insurance type from the private sector. Many dialysis patients actually also have Medicaid coverage, and Medicaid coverage is issued due to either poverty or disability, and it's administered by each individual state. And as a result, it's very variable in terms of how a person gets into Medicaid on the basis of the extent of their poverty. The disability is a little bit more homogeneous because that's being administered through Social Security, that determination of disability, and then flowing back to the states. But poverty is a very heterogeneous definition, and you don't have to spend much time Googling to find all of the political energy we spend on Medicaid in this country. Medicaid actually pays for your Part B premium, and it auto-enrolls you in Part D. So to put this alphabet soup together, one of the great oddities of USRDS data is that the patients who are the most vulnerable, who are basically poor or disabled and have Medicare coverage, are the ones that have no selection bias in terms of the selection of all of their claims into the USRDS data set. These are the patients we call duals. They're both enrolled in Medicare and they're enrolled in Medicaid. And by virtue of that, they're auto-enrolled into prescription drug coverage and pay no subsidies. There's no premiums, there's no co-pays for individual prescription drugs. Everything is co-pay free. And so when you see an analysis of patients with dual Medicare, Medicaid coverage, you can rest assured the USRDS has all the data and there is no selection bias in acquiring that data. The only problem is that the target population is poor or disabled. It's not young and healthy, relatively speaking. The health insurance status, even within the Medicare segment, is quickly evolving. You can see a variety of segments here. Just in general here, the blue and the dark red refer to those patients who are in traditional Medicare. The gray sliver are those dialysis patients, and these are specifically incident hemodialysis patients who are enrolled with private insurance, and that number runs around 10% in this country. They have Medicare as a secondary payer. That's why the label is MSP, but their primary payer is employer group health insurance, so private insurance. Then we have Medicare Advantage in green, and then a variety of other sources of insurance, including federal sources through the Veterans Administration, through military benefits that are in blue. There's a lot of different things going on in this blue segment. The thing I want to draw your attention to is the green segment. And you'll notice that as a share of the incident population, it is rapidly growing, especially in 2021, where that chunk goes from here to something like this. In the peritoneal dialysis population, the same pattern is true. I will also mention that in the peritoneal dialysis population, due to its relative youthfulness, you'll notice that the gray segment, which is the private insurance, is about double the width. So just keep in mind that anytime that somebody shows you an analysis of hospitalization data within the context of PD, you're looking at a data set that covers this blue and red bar effectively, which is about half of our PD population. And it's not the young half, it's the older half. And it tends to be the half that has already aged in, because there's a coordination period between private insurance and Medicare. And so if you start on PD as a new dialysis patient, and then you experience peritonitis or have catheter problems and discontinue PD within the first year or even within 18 months, you're likely going to be moving to in-center, and you're not yet going to be eligible for Medicare if you had private insurance from the start. And so these patients that are in Medicare on home therapies, they tend to be a little bit, they were successful enough on therapy to survive an early technique failure, and they tend to be older. And so again, you're getting this contortion between you think you're looking at data that's generalizable, but in fact, you're not really looking at data that represents your characteristic home dialysis patient. Medicare Advantage is growing, known by wonks as Part C. It basically wraps up all of these insurance products into one tidy plan. And then for ESRD, CMS actually pays an insurer a capitated payment amount per member per month. The insurer administers the plan benefits. The good parts of this is that by statute, Medicare Advantage does not have it has an out-of-pocket maximum, and it can include vision insurance, dental insurance, things that traditional Medicare, believe it or not, does not cover. Traditional Medicare doesn't have an out-of-pocket maximum. There is no vision coverage. There's no dental, with some rare exceptions, because you have a dental infection that could result in a metastatic infection. Some of that stuff is covered, but routine dental care is not. The bad parts of Medicare Advantage is that the insurers use all of their tricks, prior authorization, narrow private provider networks designed to constrain utilization of medical therapy. And so you have this really challenging environment where somebody is in Medicare, but not necessarily in an open network that allows them to access all indicated medical therapies that are prescribed by their physician. The 21st Century Cure Act was passed in the late 2010s, and it changed this landscape for payers in the country, whereby for dialysis patients. Previously to that, incident ESKD patients could bring Medicare Advantage with them. So if they had a Medicare Advantage coverage while they had CKD for many years, they could continue to keep that coverage once they started dialysis. But what you couldn't do was switch from traditional Medicare to Medicare Advantage while you were a standing or existing dialysis patient. The Cures Act removed that prohibition starting in 2021. And that's why you saw those chunks of Medicare Advantage expand so rapidly as we go from 20 to 21. And that while that flood has definitely slowed, it continues bit by bit each year. You can see from this paper that was published in JAMA Network Open, the first big chunk of switchover in the beginning of 2021. Open enrollment in this country tends to start around mid-October and then extends through early December. And so open enrollment for Medicare allows you to make your selection then, and then your enrollment switches on January 1st. You know, we get to the beginning of 2022, there's another bump. I would also point out that that if you stratify this figure based upon whether somebody is a dual, particularly in this again is poverty, Medicaid enrollment at the same time, you'll see that whether it's the orange or the blue, which are different characterizations of how long somebody was in Medicaid during a year, those are actually preferentially moving. And that sort of makes sense. Remember, I said there's no out-of-pocket maximum in Medicare Advantage. If you're a relatively poor person, there's a lot of appealing aspects of Medicare Advantage in terms of financial security. And you're not necessarily thinking about narrow networks or prior authorization. You're thinking about what am I going to do to provide me with some level of financial security. So as this transition is happening, just keep in mind that that also contorts what the USRDS reports, because anytime the traditional Medicare becomes the denominator for an analysis, it's becoming a somewhat healthier, somewhat more resource-rich population of dialysis patients than it was historically. So when you see a year-over-year change from 20 to 21, you might say, well, that's because COVID is going away. I would counter, it's not clear that it's because COVID is dissipating. It's because the denominator is changing as people leave the denominator to go to a different payer product. So that's why this is all very complex. MA is a real threat to the USRDS. I'll make no bones about it. Fee-for-service claims are very timely. At this moment, the USRDS is about to report data from 2022, but the USRDS has the ability to access data more timely. At this moment, any researcher in this country can access fee-for-service claims from the second quarter of this year, right now. Medicare Advantage data are not timely. The most recent data that are available to any researcher are from calendar year 2022, because the claims data go to the insurers first, and then at the end of the year get turned over to CMS for final review and some financial adjudication, and then finally turned into researcher products. So there are already evidence in the USRDS of figures where you see fee for service through 22, Medicare Advantage parallel figure through 21. That gap or discrepancy is not going away for any time in the near future. And that makes for an even more confusing presentation. So that is where things stand. A note about CKD, and then we'll go into some data about ESKD. There is no national registry of CKD in this country. The USRDS analyzes whatever it can access, whether that's fee-for-service claims or any other type of claim. The common thread of this is that whenever CKD is identified, because it's coming from a claim, it is, by extension, defined by an ICD-10 diagnosis code. There is no lab data about GFR and albuminuria within the USRDS ecosphere. And so there is, no visibility in a serious, validated lab kind of manner about CKD stage or KDIGO stage between CKD and albuminuria extent. We're relying entirely on ICD-10 diagnosis codes, and there isn't one for macroalbuminuria that is used with any great reliability. So this is a real challenge. And it means that, while the CKD data in the USRDS is interesting, it must always be taken with a great degree of skepticism about what exactly it means to talk about progression of CKD, severity, risk prognoses, et cetera. All right, so let's get into some data about incidence of ESKD. This is the figure that people are typically accustomed to seeing. This is the absolute annual number of patients with newly diagnosed ESRD, as the government calls it, or ESKD, as we tend to call it in the clinical domain. That figure has been going up for a very long time, and then since about 2019, relatively stable. I tend to discourage people from overinterpreting the sawtooth pattern since then. Obviously, with the timing of COVID winters, you can get various perturbations between one side of December 31st versus the other. The general pattern here is that it was a linear increase year over year, and then for about the last 4 or 5 years, it's been flat. Now, that suggests that the United States has a great epidemic of end-stage kidney disease that has only recently been abated, but I think that the story is actually quite a bit more complex than this. Here's unadjusted incidence. So there's no case mix adjustment in this. This is just normalizing for the growth of the US population underlying. And so you have a denominator or a metric of cases per million people. You can see that that number reached about 415, 420 new cases per million people, and then has flattened out and actually has come down to the point that in 2022, that incidence rate was about 380 per million people, down about 10% from its peak a few years earlier. That's unadjusted. Now, we know that the United States population is aging. When we look at adjusted ESKD incidence, we see virtually the opposite pattern of what we saw in the absolute count of newly diagnosed patients, with a trend that's been decreasing really steadily since about 2006. Now, we can talk about all of the different theories about why this has come to be, but again, we are registering diagnosis of end-stage kidney disease and the treatment thereof very reliably in this country. So I don't think that you can say this is some great ascertainment bias. This is truly real incidence. And while case mix adjustment is for both age, race, ethnicity, and sex, it is the age adjustment that drives this trend, by and large. And so this is really, in my opinion, a clear indicator that CKD progression has been slowing for a very long time. I don't have a slide today, but there was a paper that was published, I believe, in AJKD about a year ago or so that looked at GFR progression rates, per mil per year in the placebo arm of RCTs over the last 30 years. And you can see that that rate has been slowing and slowing. And I think that that manifestation is here. The timing makes sense because you've got Renal, IDNT in the early part of the 2010s. Obviously, there aren't a lot of new therapies, but there was definitely a lot of progress made in terms of control of diabetes and management of diabetes in the US. And you can see that in a lot of general population data sets made through the 2010s. And then starting by the 2019 into the 2020s, of course, now we have the emergence of SGLT2 inhibitors. Canagliflozin published in 2019 and drugs start becoming more widely available as we get in here. Now, the indications are narrow in the US, right? We're not getting all the way to the point of non-diabetic CKD indications until the very tail end of this data set. So there's a lot of room for this to change still, but I think we're at sort of the very nascent edges. And admittedly, there's some COVID interruptions here. This dip in 2020 is directly attributable to the second quarter of that calendar year, which saw a dramatic decrease of patients who were starting dialysis. Where they went is hard to say. They certainly didn't repopulate the population in 2021. So perhaps they just made a decision to pursue conservative care. They were probably very high risk for COVID complications. And, we have that bump there. But in general, details aside, downward trend. The adjusted incidence of ESRD by patient characteristics is interesting. You'll notice that the downward trends in incidence, particularly in our elderly population, is very clearly downward. Now, if I zoom in, because these lines look a little bit flat in the middle territory, I'll zoom in on those who are under age 45. Particularly, you'll notice between 18 and 44, we're basically making no progress in this country. If anything, the incidence rate is actually a little bit higher, with the exception of this decrease in the last few years. It's a little bit higher than it was 20 years ago. So we have quite a bit of investigation and progress still to make around young adults who are progressing to end-stage kidney disease. And certainly there's been a lot of concern about new onset of diabetes in adolescents, very high rates and increasing rates of obesity and morbid obesity in young adults, and particularly in the African-American population. And I think that this is an area that needs a lot of investigation and a lot of attention still, despite the enthusiasm we have for the cardiometabolic drugs that we so often think of as being prescribed to our, older adults, elderly population. When we look at racial categories, one of the great successes here is actually the African-American population. Now, the disparity exists. That's the failure of the US system. The success is that the incidence of ESKD in the African-American population has been decreased by a fair bit, from over 1,200 cases per million to now about 950. And I would point out that while we were increasing for a few years here, and I was certainly panicked, we see that in 2022, that rate has bounced back down again. What is interesting, again, is if you zoom in on this figure a little bit, the blue line here is the white population at the very bottom. This is if you zoom in on the white population. And to me, this is a unanswered question. What exactly has happened here? Now, it certainly is the case that we're dealing with a relatively affluent segment of the US population, if you just correlate socioeconomic status with race. But since about 2016-17, the incidence of ESKD, obviously at a numerical scale that's much lower, has really fallen off the cliff. A dramatic decrease. And I think it's fair to say from pharmacoepi literature and a variety of other surveillance tools that in white affluent populations, we've seen the most rapid increase in SGLT2 inhibition because of less pressure from the financial side of all of it. So this is really fascinating. And I think this is yet another area that really needs a lot of investigation. The counterpoint to this is that what you're seeing here is a drive toward conservative care in older white people, and this is a decision not to initiate dialysis. So I don't want to lead anybody with the belief that this is being driven entirely by successful drug therapy. This could be medical decisions being made. COVID is involved in this to some extent, but this is a big decrease in a short period of time. The incidence of ESKD varies tremendously by this country, and if you know the US, you'll probably come up with some theories pretty quick about what's going on here. You're looking at Appalachia, deep into Kentucky and West Virginia here, a lot of poverty and a lot of environmental pollution deep into the Ohio River Valley. The same can be said for the Mississippi River Valley, extending from about St. Louis or Memphis, where this dark blue spot is, and goes right on down to New Orleans. Pretty dark stretch there. That'd be Missouri, Tennessee, parts of Mississippi and Arkansas. You have a Hispanic population throughout southern Texas and into parts of Oklahoma. And of course, you also have a Hispanic population rapidly growing in the Central Valley of California. In addition, in the Central Valley of California, you have populations migrating from the coast inward to escape the high prices that are along the Pacific coast. That migration is happening. I've seen it, seen it in general population, I've seen the dialysis population. So we have a variety of forces going on here, but I basically characterize as environmental poverty, economic poverty, and Hispanic ethnicity. And those create these hotspots in the United States where we see a lot of ESKD incidents. Now, as far as the modality mix goes in the incident population, it is changing. I have not shown in-center hemodialysis, but rather focused on HHD, PD, and preemptive transplant. HHD is not an instant therapy in the US. It's not an instant therapy in core data. It never really has been in any Western country. So the red line is not so important. I will point out that the gray line, which is our incident population on peritoneal dialysis as a percentage, has increased a lot. After it bottomed out in 2007, 2008 at around 6% of all incident patients, we've gone steadily up. Bundled payment was definitely a driving factor in the 2010 period. It was proposed in 2008, and so everybody had a sense of like, here's what's coming in 2011, time to react. Bundled payment was focused on drugs, but one of the other things it did was to create parity in reimbursement between peritoneal dialysis and in-center hemodialysis. And so when there was parity, there was naturally an incentive to use more peritoneal dialysis as an incident therapy, strictly for financial reasons, if for no other clinical reason. And as such, the therapy begins to grow. Bundled payment takes effect, it grows some more. We have a fluid shortage, which is another problem that we're going through again, although this time I think will be quite a bit shorter. But that fluid shortage slowed things down. And then we finally had a payment model proposed after that fluid shortage debate. We had a payment model focused on home dialysis that was proposed in 2019. So we've got growth happening again, some interruptions from COVID. But again, generally speaking, despite these interruptions and sort of exogenous insults, PD continues to grow as an incident therapy. A different thing that's really quite exciting is the preemptive transplantation is growing in the US. The 2022 number is up to 3.5%. That's the largest it's ever been in this country. The registry goes back to the 1980s. It has never been at 3.5%. And so this is really remarkable. Now, it's not the United Kingdom, where it's at 7 or 8% of patients with preemptive transplant, but it is a big increase. And I think there's a lot of organ acquisition issues and reform issues that are embedded in why this is happening, but it's a great testament to progress throughout the system. The US government is particularly focused on this thing called an optimal start. And an optimal start is defined as either receiving a preemptive transplant, starting on peritoneal dialysis, or starting hemodialysis with a fistula or a graft. That number has, as you can see from the figure, been wildly static for the last decade. There are payment models in progress right now that cover nephrology practices that are intended to incentivize optimal starts, however they can be accomplished. And you can see that in 2022, there's a little hint of an increase. The reality is that an optimal start is really not going to happen if a patient isn't seeing a nephrologist. So there is a break here, right? We have patients crashing into therapy, never having seen a nephrologist. That's about a third of our population. They're not going to have an optimal start. So you're really trying to work on the remainder and then trying to get people from primary care to nephrology practices. As for that pre-USRD nephrology care, this is tracked by the USRDS. So you can see that we can count within age brackets, how many months was a patient seeing a nephrologist before they were diagnosed with ESKD? And that number's gone up over time, but it's not dramatically different in terms of secular trend. As far as age is concerned, you can see that our elderly patients are more likely to see a nephrologist for at least 12, if not 6 months beyond, than younger patients are. Estimated GFR is as flat as can be. The IDEAL trial was published back in about 2010 or so. Certainly there was some aggressive starting of dialysis in the 2000s. And when the IDEAL trial hits around 2009, 2010, if I recall correctly, you can see that distribution of eGFR dialysis initiation is essentially flat in this country. And so it's a very stable system in terms of that decision making. As far as prevalence of ESKD is concerned, prevalence is driven by incidence and then driven secondarily by death. This is the prevalence of ESKD, and it was growing linearly because survival was improving and incidence was increasing. And then we hit COVID and it just goes flat. And the flatness can be attributed to some extent by the incidence also decreasing, but the driver factor here is mortality. And I'll show you a figure about that in a moment. What's interesting about this from the dynamics of how ESKD is actually cared for on a day-to-day basis is that flatness actually betrays that there are some real interesting trends here. In-center hemodialysis, which peaked at close to 500,000 patients in 2019, actually has decreased. And that shows no signs of growing. If you look at public reports of treatment volume from dialysis providers, growth is either near zero, non-existent, very small, sometimes negative. In-center hemodialysis is definitely an area where this country has definitely flattened out, and to me shows very little signs of future growth. There may be some due to population growth, but I think it'll be very tepid. The transplant population continues to grow, and of course the home dialysis population continues to grow. When you add up the PD population, which is in gray here, and the red population, home hemo, we're dealing with about north of 80,000 patients in home therapies in the US. So it's a very large population. And I will point out HHD, Swat made a mention about that. I worked with NxStage for a number of years, so I'd like to think I had a part in this red line going up. But in any case, we have gone through periods of growth. There was a lot of interest in HHD in the 2000s as the therapy was sort of being resurrected. That growth slowed some in the 2010s, but then Fresenius purchased NxStage around 2019, and there's a second bit of growth that happens there. So that's up to about 13,000. As far as home dialysis is concerned, I will just simply point out that this growth is very wide-based. This is across age brackets from 18 to 44 up to 75 plus. You can see the secular trend in terms of home dialysis utilization among incident patients increasing in all those age brackets. In racial and ethnic categories, we see a similar secular trend going up over the decade. And importantly, even in social deprivation categories, you can essentially think of it as poverty at the very gray line and relative affluence at the blue line. All of those have increased. And so the disparities exist. The US, I don't want to whitewash this, the US has failed to close these disparities by race and by socioeconomic status. But within each category, there is broad-based growth of home therapies. Unlike Canada, and certainly unlike Australia, the United States revels in this sort of village industry of home dialysis. You're looking at the number of patients per home dialysis program in this country, and you'll see that if you try to set aside the zeros, those are programs that are certified to offer home therapies but have no patients. But instead focus on the 1 to 10, 11 to 20. You can see that we have huge amounts of our PD and HHD patients in very, very small centers. And so to the extent that you believe in the theory that volume creates practice, expertise, and thus better outcomes, it's very difficult for the US to cross that Rubicon because so many of our patients sit in very, very small programs. I would finally caution you interpreting USRDS to beware of HHD statistics. This is a figure of the cumulative incidence of death after starting home therapies. And you'll notice with the red line that HHD sits at approximately 22% mortality after 1 year of starting therapy. Now, if you think about HHD in Ontario, and then you think about whatever your caricature is of HHD in the United States, you would say, how in the world can 22% of patients die within a year of starting the therapy? It doesn't even make any sense based upon the case mix of the patients. The reality is that the USRDS really struggles with HHD definition in our data set. And that's because in the US, if a patient is receiving hemodialysis inside a skilled nursing facility, and they live in that nursing facility, it is characterized by the federal government as home hemodialysis. It's regulated that way. The conditions for coverage, which govern the nature of care and how therapies are regulated, all of that is under the category of home. And so HHD in the USRDS data landscape is this strange mix of what you think HHD ought to be, dialyzing in your private residence, and this other very high acuity population that dialyzes in a nursing facility. And so the USRDS is making progress. The federal government has made progress on clarifying the data streams, but we're not all the way there yet. I think we will be in another 3 or 4 years, but it still is a long slog and it's very challenging to unpack. As far as vascular access is concerned, I would point out that this is in the prevalent population. You'll notice that the fistula line, which is the number that's been sitting in the mid-60s, has recently decreased. You notice the catheter dependence has increased, whether that's any catheter use or catheter use for at least 3 months. And that gray line is essentially where quality measures in this country focus on, what they call long-term catheter use for at least 90 days. Those lines have gone up, and it's tempting to think that the reality is they went up because of COVID and challenges with accessing vascular surgery. I actually think that the story is a little bit more complex than that. If we look at vascular access in the incident population, you'll notice that those patients who start, this is the vascular access at the first hemodialysis session, that percentage who start with a catheter only and not even a fistula placed and then is still maturing, that started increasing around 2017. And that actually coincides with changes that the federal government made in terms of payment to vascular access surgeons in the outpatient setting, in terms of cutting reimbursement, not for the surgery procedure, but for fistulograms and for a variety of other maintenance procedures. And I think that when that reimbursement changed, it changed the entire market around placing vascular accesses. And so the incident population begins to change in 17. And by the time we get to 2020, coincidentally, it looks like the prevalent population is changing, but it's not just COVID. Mortality has been discussed a lot. Mortality increased in 2020, and the only thing I'll say about the USRDS report is that as of 2022, whether it's in in-center HD or PD, those numbers have not yet come down. They're tracking very closely with excess mortality in the general population, but they're not back to where they were pre-pandemic levels yet. Patients who might progress to ESKD is the last thing I'll cover today in the last few minutes. Again, I mentioned that this is not a registry per se. This is an analysis of claims data in patients identified with the CKD diagnosis. Now, the mortality rate in our older population, which is technically age 66 and above, a claims-based diagnosis of CKD, and then a diagnosis with a CKD3 or CKD4 diagnosis on a claim, so a diagnosis code or a 5. If we look at mortality rates, you'll notice some interesting things. There's a lot of trends here, so it's hard to unpack in one short phrase. Certainly in this 4 or 5 population, you see the COVID bump in the mortality rate. From 2019 to 2020, that rate goes up and then it's come back down. I think you can safely interpret that as sort of a good realization of clinical reality. In CKD3, you'd say, well, this is interesting. Why is the mortality rate changing so dramatically over time? And this is a relatively big mortality decrease from 2012 to 20. Yeah, there's a hint of a COVID bump here. I think that this, again, speaks a little bit to the challenges of using CKD data in USRDS. CKD stage coding has improved dramatically since the early 2010s. People use these codes. And so I'm not convinced that this is progress. I think this just may be the denominator filling in with more people using the CKD3 diagnosis. And as such, we're just seeing epidemiologic drift in this population. Whether the death rate has actually changed in CKD3 is highly contentious, in my opinion. I would not interpret this as progress, so to speak. As far as the Medicare Advantage population, we can see in 2020, stages 3, 4, and 5, we see that bump going into the pandemic. And then in the Medicaid population, we can also calculate death rates. Now, the Medicaid population is younger adults under age 65, but you'll notice that in 2020, 21, 22, we see these bumps, and then we see a gradual relaxation in mortality rates. So we can estimate mortality rates across all of these payer segments, but I really want to focus on medications as we wrap this up, because ultimately the question is around ESKD incidences, where is it going to go in this country? And I think that the connection to where it's going to go is how are we treating patients with CKD with pharmacotherapies. You're looking at ACE inhibitor ARB use in the CKD3 stage 3 population, stratified by payer and stratified by diabetic status, and then also stratified by white, Black, and Hispanic status. This figure is interesting, right? You might say, well, why is the Hispanic population treated more aggressively than the white and Black populations? This speaks a little bit to Part D, and it's the auto enrollment and the lack of co-pays and the lack of financial barriers. And so you get these deviations that sometimes are a little counterintuitive. But in any case, we treat our diabetic population a little bit more aggressively. You'd expect to see more albuminuria there, so the indication exists. But these percentages range anywhere from about 50% up to about 75%, okay? SGLT2 inhibitor use in stage 3, CKD stage 3 is an evolving process. You can see huge disparities in 2021 data between diabetes and non-diabetes. Now, this is pre-empikidney, so we don't have a non-diabetic CKD indication yet, but big disparities between the three. Medicaid in many states is very generous with empagliflozin, as well as dapagliflozin, but like in Minnesota, this has been available on formulary inexpensively for a very long time now for Medicaid beneficiaries. And you see the fruits of it. When you remove financial barriers, the medication gets used more aggressively. When we stratify the population by diabetes and heart failure within the CKD, you'll notice that the gray and the blue bars, which correspond to diabetes with or without heart failure, are very high. When we get into the non-diabetic population, yes, there's an effect where patients are receiving SGLT inhibitors through a cardiologist, probably because they have heart failure. But if they don't have diabetes and heart failure, but they do have CKD, preciously little use at this point in 2022. And then finally, the last thing I'll point out is the use of these medication classes outside of SGLT2 inhibitors, and particularly GLP-1 receptor agonists. That's the blue line, and you notice that it's increasing very steadily. In 2022, that number has gone above 10%, and it is continuing to go up as we go. DPP-4 inhibitors are decreasing. My argument is they don't have cardiovascular outcome data supporting them, so why would you use them? Metformin use has gradually increased all along the way for the last decade or so. Interestingly, even in the dialysis population, the GLP-1 inhibitors are beginning to catch fire. You can see that since about 2018, the use is going up. Now, this is largely liraglutide. So we're not seeing a lot of semaglutide and certainly no tirzepatide in this data set. But the liraglutide data is definitely flowing through into the dialysis population. I think this will be a great area for a lot of pharmacoepi use in the future. So to wrap this up, the question posed at the beginning was constant evolution or more of the same. I really debated where to put my arrow actually as I was wrapping up creating these slides. I have to say that I ultimately argue that there is constant evolution. I also thought about putting a picture of a little tortoise on the side because I think that the evolution tends to be a little slow, but there are a lot of signs. This is not a static system. I think that the frustrating part of the system is that it's hard to find the signals because of the multi-payer nature of data. And unfortunately, or fortunately, depending on your great love of market forces, this country tends to move more aggressively when there's a financial reason to do so. And so when you're relying purely on clinical evidence, practices change slowly. When there's a financial engine that can push clinical evidence, things change more rapidly. And you see the footprints of that all over the place. Again, the incidence of ESKD is a great indication that we're making overall progress. But then you look at disparities that aren't closing and you say, well, it's great that we're making progress, but how come we can never close disparities? Why can't we roll out effective, efficacious therapies faster? And that's where the frustration sets in. So I do press the constant evolution button, but I will sympathize with anyone who wants to press the other button. And with that, I'll wrap it up, open to any questions.
Thank you, Eric. That was a wonderful overview. I love how you drill down into the graphs and maybe more than anyone else could do. I wish you were a reviewer or someone like you on all ESRDS papers, because I'm sure there are some misinterpretations. Exactly, as Mark is putting in the chat, is that often peer reviewers do not understand the limitations of the data sources. Do you have any comments on the whole? How do journals understand USRDS issue?
It's an interesting question. There have certainly been plenty of papers that end up in JSON or CJSON, and I ask myself, I asked some of my peers at the USRDS, why didn't you get an invitation to review the paper? I would never expect that a journal ask a USRDS investigator to review every paper. The truth of the matter is that when you use USRDS data as an external researcher, before you can submit a paper to a journal, you actually do have to submit it to the NIDDK for a cursory review. That review is actually designed to cover compliance with privacy requirements. And the privacy requirements mean displaying no cells that involve 10 or fewer patients. Those need to be censored. And so you put an asterisk in place of that single-digit number. The NIDDK does not review the actual content of the paper or the scientific credibility of it. I have wondered sometimes, would the system be better if during that process, a USRDS Porting Center employee also looked at the paper? But that would be injecting somebody who is to some extent a scientific competitor. They're not associated with the journal. I mean, I could understand why people wouldn't like that either. I don't know what the answer is. I'm always happy to accept a review, but sometimes, I'm an epidemiologist, and so obviously I understand a journal wants to submit a paper to 3 or 4, physicians who know the content area really well from a physiologic perspective and review it there. That's going to happen. And then unfortunately, things do get missed. There have been definitely instances where papers have been royally screwed up. I was involved in one that was, that one was through JAMA and had to do with transplant. That was more of a coding error rather than misinterpretation of data, but it should have been caught by the reviewers. Just for the face validity lacking in the data. But there have been pharmacoepi studies that I think are a little bit dubious. We talked about ondansetron or Zofran recently on FGC. I have concerns about the validity of exposure ascertainment there. There have been some papers about gabapentin that are a little bit dubious because of the nature of data there too. So pharmacoepi is a challenging one, and I think people do make mistakes.
And Eric has been modest about the JAMA thing. There is I can to people who are interested, I can share the longer story later on. The cause of death. So Whale has a question in the chat, and even I had the similar question on mortality. So yeah. Whale is asking, is it the cause of death that's a problem, or whether death has occurred?
Yeah, cause of death is the issue. So the ascertainment of death is an interesting question. The last time that the USRDS did a gold standard validation against the National Death Index was in the early 2010s. And the reason I say it was gold standard, and it was then, was there has been since about 2015-16 a bit of a fight at the federal level in terms of state data flowing into the National Death Index. And so you can't even do a gold standard analysis right now. But back then, we compared what's in the NDI, which is Social Security's recognition of death in the general population, with what USRDS had, and it was a sensitivity of about 99%. So I think it's very, very good. I do think that in the undocumented immigrant population, there are some questions. So if you are looking at trends specifically in deaths in the Hispanic population, especially in Hispanic in the Southwest, I would be a little bit worried about death ascertainment, but those are the exceptions, not the rule. And then as far as cause of death, yeah, that's a challenge. Cause of death is not collected for 20% of our dialysis patients. So there's just a big missing cell. I think that the sudden cardiac death is admittedly a bit of a fallback. Nobody really analyzes secondary causes of death on that death notification form with any great rigor. But I've always been dubious that we just have 40% of dialysis patients suddenly dying at home with no other cause. So I worry that that data tends to be a little bit overinterpreted.
Interesting. Greg.
Thanks, Eric, for that talk. The slide I thought was really interesting was the age-adjusted drop in the incidence of ESRD.
Yeah.
And does that data have any of the caveats of data that you reviewed in the first 20 minutes? That's what I wanted to get at.
Yeah, it's a good question. So the only, I mean, again, the incidence is not going to be recognized in the registry if the patient has not been discharged from the hospital or has not chosen to initiate dialysis in an outpatient setting. So what we're missing, and Rob Foley wrote a paper about this. He always had very coy kinds of messages to his paper when he was deputy director of USRDS, but he wrote a paper about missing death in the early part of the ESKD. Missing death is a bit of a misnomer because we are collecting the death data about those patients who are in the denominator. But his point was, why is the death rate actually a little bit lower in the first 2 to 3 weeks of dialysis than it is in the second month or the third month? And the argument here is that if we had the definition from an RCT of kidney failure of, persistent GFR under 15 or initiation of kidney replacement therapy, our incidence rate would be higher. And then that death rate profile in the first months of dialysis would look different. It would probably be monotonic. Now, does that unrecognized kidney failure actually change this ESRD? You would have to argue that there has been a dramatic shift toward conservative care and the decision not to initiate dialysis. And while I think that there's some footprints of that in the over 85 group, I don't think that that's a very credible explanation for anything between the ages of, say, 45 and 75. So I don't have a lot of skepticism about this, but I will say to your point that there is some reason to be concerned that maybe this blue line at the top is a little overstated.
Thank you.
So, and again, on the same point, I was kind of optimistic that, what you've shown is perhaps the effect of, better BP control and diabetes control and ACE inhibitor use. But then how do you explain the race trends then? Like in the white population, there was no effect of ACE inhibition for 20 years. Again, I guess we are trying to interpret too much and the data cannot tell us all these answers, but how would you look at that, the decrease by race?
I think so. I think that it's important to recognize that the adjustment is age, race, and sex, and it doesn't adjust for underlying comorbidity management of those comorbidities. And so, for instance, we've seen cardiovascular death rates and particularly a lot of heart failure metrics deteriorate in the United States general population since about the mid-2010s. And so there are a lot of countercurrent forces going on at the same time. Medicaid expansion has probably had a lot of general population effects in terms of decreasing mortality rates. There were papers published around 2016-17 specifically about the nature of dialysis initiation that suggested that in Medicaid expansion states, we were seeing better preparation for ESKD. But then you have a lot of people Yeah, I mean, think about where Medicaid expansion states are. They're happening at all sorts of different times, but you have a lot of states in the northern part of the country and the western that expanded early. The deep south is not expanded to this date, but even in my area, Wisconsin to this date still has not expanded Medicaid. Minnesota has, and so you get very heterogeneous patterns in terms of these payer forces driving clinical outcomes. And it is hard to make sense out of what's going on unless you really drill down to geographic locales.
That's a good point. I think we are at the hour, but if I can squeeze in one question, is the lack of data on CKD. I was looking at the CKD stuff, and NHANES used to do it more regularly. They haven't done anything since March of 2020. So it's only the claims data, which you pointed out are not really good quality. Is that going to change at all, or are we going to be in a
that will that will change next year, as far as I know. The NHANES chapter, which is typically CKD chapter 1, if you look at the NHANES website today, actually many of the data sets were released in September, so just a month or 2 months ago, and so that data was just not available in time for inclusion. Now at this moment, actually the creatinine values and the albuminuria values, that standard lab assay part of NHANES, that data set is still not available, so I'm sure it will be released in the next few months. But the NHANES was delayed. It was delayed by COVID, and it just wrapped up its survey sample in the early part of 2023, and now the data are being promulgated. So I would expect that chapter next year, but not before then.
Okay, that's really good to know. Thank you. So thanks again for that fantastic overview and waking up early to present to us from Minnesota.
You're welcome.
And it would be wonderful to have you here in person someday. But until then, thanks for this presentation.
All right. Thank you very much. Have a nice day.